Welcome, and thank you for joining our conversation about living with Waldenström's macroglobulinemia. The Leukemia and Lymphoma Society is now Blood Cancer United. Blood Cancer United is an evolution, not a new beginning, that will help us meet our bold goal to enable patients with blood cancer to gain more than 1 million years of life by 2040. With the name Blood Cancer United, we can now reach more people who need us, people affected by all 100 plus types of blood cancer. Our mission is not changing, and we will continue to be a global leader in blood cancer research, support, and advocacy. With your help, we have invested more than $2 billion in groundbreaking research supporting many of today's most innovative approaches to treatment, helping those with blood cancer not only survive, but thrive. Blood Cancer United helped advance more than 70% of the blood cancer treatments approved by the FDA, the US Food and Drug Administration, over the past 2 decades. Waldenström's macroglobulinemia, or WM, is a rare and typically slow-growing subtype of non-Hodgkin lymphoma that affects white blood cells. Blood Cancer United has supported most of the therapies for use in Waldenström's today. Blood Cancer United is currently supporting several novel treatment approaches for Waldenström's, particularly through precision medicine and novel immunotherapy. Beyond this, Blood Cancer United currently maintains a portfolio of over 50 active grants in non Hodgkin lymphomas, and much of the knowledge gained in our understanding of non Hodgkin lymphomas has been applied to Waldenström's today. It's my pleasure to introduce Dr. Joshua Richter, who is an associate professor of medicine at Tisch Cancer Institute and Icahn School of Medicine, and is also director of myeloma at Blavatnik Family-Chelsea Medical Center at Mount Sinai in New York, New York. Dr. Richter, I'm privileged to turn the program over to you.
Thank you so much, Lisette, and huge thanks to Blood Cancer United for everything they do to help patients with blood diseases. Really excited to work with you and your team. And today we're going to discuss Waldenström's macroglobulinemia, which is a big focus of my practice. Here are my disclosures. And ultimately, I think you brought it up in the perfect way that Waldenström's macroglobulinemia represents a somewhat rare subtype of non-Hodgkin's lymphoma. And although we've understood that there are literally hundreds of different types of lymphoma and other blood cancers, we need to approach each of them in a different and unique way, not just from a therapeutic standpoint, but from a diagnostic standpoint as well, to make sure that all patients have the optimal outcomes. So here, it's a little introduction about the disease. And essentially, although there are literally hundreds of types of non-Hodgkin's lymphoma, there are really two key criteria for diagnosing someone with Waldenström's macroglobulinemia. The first is a lymphocytic infiltrate in the bone marrow. And if we think about lymphocytes, and lymphocytes ultimately terminally differentiate into plasma cells. And when a lymphocyte becomes a malignancy, that's lymphoma. When a plasma cell becomes malignant, that's myeloma. Lymphoplasmacytic lymphoma, or Waldenström's, kind of lives right in between those two. Additionally, this disease is noted for having a monoclonal IgM protein in the blood. So if you look for these abnormal proteins by immunofixation or electrophoresis, we find some of these misfolded proteins or antibodies made by the malignant cells in the blood. Again, it's a relatively rare disease, representing only about 3 cases per million in the United States. It's less than 2% of all non-Hodgkin's lymphoma, and overall a somewhat uncommon disease overall. Now, when we look for these abnormal proteins in the body, they don't just represent Waldenström's. They're actually associated with a variety of different diseases, the most common being what we call MGUS, or monoclonal gammopathy of undetermined significance. This is where we find that abnormal protein, or M spike, and the overwhelming majority of them are completely benign and never evolve to anything like a blood cancer. However, there are a number of malignant conditions that can evolve from these abnormal cells, including myeloma and lymphomas like Waldenström's macroglobulinemia. Additionally, the IgM subtype is almost never myeloma. It can be, but is extremely rare. The majority of IgM M spikes are going to be MGUS, which are still benign disorders that do not need treatment but simply monitoring. But apart from Waldenstrom's, they can also be associated with a variety of other disorders, including other non Hodgkin's lymphoma like CLL or follicular lymphoma. They also can be associated with AL amyloidosis as well. There are certain signs or clinical presentations of Waldenstrom's, and although many patients will actually present in an asymptomatic way, one of the most common ways that this disease presents is patients go in for yearly blood work and routine chemistries show an elevated total protein level. And remember that antibodies are proteins. So, a further workup of this elevated protein level can reveal these abnormal antibody proteins, and patients can subsequently be diagnosed with Waldenstrom's macroglobulinemia. Now, in general, when we think about non Hodgkin's lymphoma, and the majority of these are going to be B cell non Hodgkin's lymphomas, although there are hundreds of types, we can divide them into two broad categories: high grade aggressive or low grade indolent. The high grade aggressive are typically things like diffuse large B cell lymphoma, Burkitt's lymphoma, where some of the indolent ones include follicular lymphoma, marginal zone lymphoma, and Waldenstrom's. The indolent or low grade lymphomas, like Waldenstrom's, are often asymptomatic, but when they do evolve to needing therapy, often present with signs or symptoms related to cytopenias or low blood counts, notably things like anemia. And when patients are anemic, they can feel fatigued, weak, or short of breath. Thrombocytopenia or low platelet count, which can be associated with bruising or bleeding. The B symptoms that we classically associate with high grade lymphomas, things like weight loss, fevers, or large lymph nodes, are somewhat rare but can be presenting causes of Waldenstrom's macroglobulinemia. And of course, that protein that circulates in the blood is rather large. Macroglobulinemia literally just means large protein in the blood. And if you have too much of this, the blood can flow slowly and can be kind of viscous, almost like ketchup or molasses. And that sludging that we call hyperviscosity can lead to a variety of symptoms as well. Again, the criteria from the World Health Organization are simply that a patient has this lymphoplasmacytic infiltrate in the bone marrow. Again, it looks like it's in between a lymphoma and a myeloma, and the monoclonal IgM, that abnormal IgM protein in the blood. There are additional, more specific criteria that we look at called the immunophenotype. All cells in the body have markers on their surface that differentiate them from one another. So we call them CDs, or clusters of differentiation. And there's CD 1, 2, 3, up to CD 600. And each type of cell has a variety of these different markers. Waldenstrom's malignant cells tend to express CD19, CD20, and they have that IgM on the surface, and a variety of other variabilities in things like CD5 and CD10. Now, again, not all IgM paraproteins are going to be Waldenstrom's. The Waldenstrom's that we classically talk about have more than 10% of the bone marrow taken up by this abnormal collection of cells, along with the IgM protein. An MGUS is where there are fewer than 10% of these abnormal cells and no symptoms. And we often use the term smoldering Waldenstrom's for patients who have 10% or more of the abnormal cells in the bone marrow, but still have no signs or symptoms of low blood counts, hyperviscosity, or any other B symptoms. And those patients are typically monitored. Now, when it comes to anything we're discussing in the world of modern day cancer, we like to look at the genetic changes that give us predictions both of how people will respond and what therapies may be the best to utilize. In Waldenstrom's, there are two main genomic abnormalities that we tend to look for, both in the blood and in the bone marrow. These are abnormalities of MYD88 and CXCR4. These are both markers that can be either wild type, which is the normal version, or they can be mutated. Now, these can help us differentiate the different types of lymphomas and ultimately help to parse out what type of lymphoma is more consistent with Waldenstrom's. As noted, around 90 to 95% of patients with Waldenstrom's macroglobulinemia will have an MYD88 mutation, whereas only about 30 to 40% of patients will have a CXCR4 mutation. And ultimately, you can have all four groups of that little Punnett square. Both MYD88 and CXCR4 can be wild type. They can both be mutated, or one or the other can be mutated. Now, we also note that the different types that we see, the different phenotypes of the disease, may have not only different responses to different treatments, but also different types of presentations. We can see here that patients who have dual mutated disease tend to have more Waldenstrom's in the marrow, more bone marrow infiltration, and therefore may present with more low blood counts. Additionally, although there are many, many types of treatments, one of the main FDA-approved therapies for Waldenstrom's, which many patients may be on, are a class of drugs known as the BTK or Bruton tyrosine kinase inhibitors. These drugs block a survival mechanism of the cancer cells, and as we can see, patients that have dual wild type, which is a relatively rare version of Waldenstrom's, tend not to respond well to that type of treatment, but can respond to many other treatment modalities. Now, once we diagnose a patient with Waldenstrom's, we don't necessarily jump right into treating because it's important to differentiate between smoldering disease that simply needs to be observed or truly symptomatic disease that warrants some type of therapy. And again, the way that you present and the aggressiveness of the disease may dictate which option we choose. There are certain clinical and laboratory indications for us to start some type of treatment. The classic clinical indications are patients who present with more aggressive disease with B symptoms, night sweats, fever, weight loss, hyperviscosity, so if the blood gets too thick, we need to act rather quickly, symptomatic organomegaly, recognizing that organs like the spleen are essentially large lymph nodes, and when the spleen gets too big or filled with this Waldenstrom's, it can press on the stomach, and patients can have abdominal discomfort or what's known as early satiety. Early satiety is when you sit down for a meal, you take 2 bites and you're already full because the spleen is compressing the stomach. Or neuropathy, recognizing that because these are abnormalities or malignancies of immune cells that make antibodies, sometimes those rogue antibodies can attack the nerves and cause numbness, tingling, or even pain in the nerves, typically in the extremities like the hands and feet. There are certain laboratory indications for treatment, and this can be as a function of either the bone marrow filling up with the bad cells and crowding out the healthy ones so the blood counts drop, or again, just like we can make antibodies to fight infections or antibodies to attack nerves, sometimes the antibodies can attack our own cells, and the antibodies attack either the red blood cells or the platelets. You can have low blood counts. So patients with hemoglobin less than 10, platelet count less than 100, or any signs and symptoms of laboratories showing us that the antibodies to attack the nerves or other vessels are there, those are indications to start some type of treatment. Now, in many cancers, we recognize that once we diagnose something early, even if it's before we develop symptoms, there is a benefit to treating. We recognize this from things like breast cancer and other types of early malignancies like colon cancer. However, in Waldenstrom's, and this is true of many different types of blood cancer, simply finding the disease does not show any benefit in early treatment, and it's definitely better to wait and not just treat the disease because we found it. In fact, we note that many patients with smoldering Waldenstrom's may never warrant any therapy at all. So it's important to have your disease not just properly evaluated and diagnosed, but have a very in-depth discussion with your care team about whether or not it's worthwhile to treat or not, and are there any advantages of intervening early. Now, our colleagues at the Mayo Clinic have a website called msmart.org, which is a wonderful website that contains a variety of resources both for care teams as well as patients. And they have a consensus guideline for patients with IgM gammopathies associated with diseases like Waldenstrom's. And we can see here that they group them into 3 categories. Category 1 are patients with completely asymptomatic processes, either IgM MGUS, smoldering Waldenströms, or patients that may have only mild lowered blood counts but absolutely no symptoms at all. All of these patients are recommended to be simply observed. Now there are patients that have mild symptoms, either an immune related low blood count, such that the amount of disease is not heavily burdensome, but you have a rogue antibody attacking your platelets or your hemoglobin, or some type of abnormal protein affecting the blood vessels, in which case we oftentimes give a antibody that targets the malignant cells called Rituxan. It targets CD20, which is almost universally expressed on all Waldenstroms, and we often give just one course of this, which is 4 doses 1 week apart, and that's all many of these patients may need. This is in stark contrast to patients who present with fully symptomatic Waldenströms with bulky disease, meaning they have a lot of it, or they have really low blood counts, not a hemoglobin of 10 or 11, but maybe a hemoglobin of 6, 5, or lower. Low platelets, and I'm not talking about 90 or 100, I'm talking about 30 or 40, or any constitutional symptoms, and very specifically if they present with hyperviscosity. In these cases, we'll talk about some of the treatments and their different modalities and mechanisms. However, these patients require full treatment for Waldenström's macroglobulinemia. And again, we have many, many different options of how we can treat the disease. One of the benefits of the disease living kind of in between a lymphoma and a myeloma is that we can use almost any lymphoma treatment, and we can use almost any myeloma treatment, and we can mix and match, which means although it is a rare disease with limited clear guidelines, we actually have a lot of flexibility and can very much tailor our treatment to patients in a variety of clinical scenarios. Some of the considerations we use to decide what course of treatment is: how are you presenting? Are you presenting in the hospital with very acute symptoms? Have we known about the disease, and is it gradually growing in a glacial pace? And we have time and we may want to give just a little bit of treatment. What are your treatment goals? Are you 30 or are you 95? Some treatments are treatments forever. You take a pill and you stay on it as long as you live. Some are just fixed duration. Some are more toxic than others. All of these considerations going into finding you the optimal treatment. Now, one of the most important things that helps decide what our first type of treatment is going to be is what I like to think of as kinetics, meaning how quickly do we need to turn the disease around? Has this been smoldering for many years and is now just tipped over to where we need treatment, and we can give a therapy that is gentle but may take months to work? Or are you acutely ill in the hospital, and do we need to give you some type of treatment to turn this around immediately? The second group is very much associated with a disorder known as hyperviscosity. On the right, we can see diagrams of some of the more common antibody proteins that circulate in the blood. The majority of antibody proteins are immunoglobulin type G, or IgG. They exist as monomers, basically one antibody. IgAs tend to exist as dimers, two stuck together. But the IgM protein that's associated with Waldenström's tends to exist as both a pentamer and a decamer, 5 at a time. And because this protein is quite big, it makes the blood flow sludgy and not flow where it should be. And this can lead to signs or symptoms of what we call hyperviscosity, where the blood flow is not getting to where it needs to be. Some of the symptoms associated with hyperviscosity are headache, blurry vision or loss of vision, dizziness, trouble breathing, nosebleeds. It's important to discuss with your healthcare team because many of these symptoms can be related to other things. At the time of this recording, we're starting to get some really cold weather. At the time of cold weather, you may have baseboard heating that floods in without any hydration, in which case you can get dry mucous membranes and nosebleeds that have nothing to do with the viscosity of your blood. So again, it's important to discuss with your team. However, once we have someone with hyperviscosity, we consider the first order of business to do what's called plasmapheresis or plasma exchange. The way I like to think about it is that Waldenström's is the disease, and the protein of hyperviscosity is like a building on fire. Sometimes in order to get to the fire, you need to wave away the smoke. That's exactly what plasmapheresis does. It doesn't kill the bad cells, but it clears out that big protein from the blood, and then when we give the chemo or whatever the immune therapy is, that allows us to treat the fire at the base, kill the bad cells that are making the IgM. But because that may take a little bit of time, the plasma exchange just takes out the plasma with the IgM in it, wiping away the smoke so we can see the fire more clearly. Also, we use an IgM level of around 4,000 to decide whether or not we're going to use that rituximab drug or not, because when that drug is administered, we can see a brief flare of the IgM. So if the IgM is sitting around 4,000, we tend not to give Rituxan up front because it may shoot you into hyperviscosity territory before it lowers. So we sometimes give other therapy to lower it first and then add on the Rituxan after. Now, Waldenstrom's has been known about for many years, and throughout the years, it has mainly been associated with treatments that parallel that of indolent lymphomas, using classical chemotherapy drugs like fludarabine and cyclophosphamide, and ultimately somewhat pairing them with the antibody drugs like Rituxan. However, one of the big things that's changed across the last 10 to 15 years has been the advent of BTK inhibitors. Bruton tyrosine kinase inhibitors are a mainstay of therapy, and there are a number of them available to treat Waldenstrom's. However, Rituxan continues to be one of the mainstays of treatment. Again, it can be given for minimally symptomatic disease or in combination with other therapies for more bulky disease. Again, Rituxan targets the CD20 marker that's on all of the malignant Waldenstrom cells, and we can see here some of the data about combining them with a variety of different lymphoma-based therapies, as well as combining it with myeloma-based therapies. Again, it's very important that we decide what option to do because some will work quicker than others. For example, Rituxan plus CHOP chemotherapy is a more aggressive and classical chemotherapy or chemoimmunotherapy-based approach for Waldenstrom's. It can be a little more toxic, however, it's extremely effective and works very fast. However, regimens like rituximab and bortezomib, combining the immunotherapy of Rituxan with immune therapies from myeloma, can actually lower the disease quite well with minimal side effects. Bruton tyrosine kinase inhibitors have become some of the mainstay of therapy ever since the approval of our first available drug in this category called ibrutinib. The best way to think about it is that kinases are signaling pathways within the cells to keep them alive. They can be blocked, and basically the cell that was dependent upon this is now forced to shut down because this is an essential part of the cell's survival. Now, we have known from the beginning that drugs like this, like ibrutinib, work very well as monotherapy. And we can see here that if we look across the majority of Waldenstrom's, although this drug is slower to work, it works extremely well. And again, it's just a pill. It tends to work less well in the rare subtype of dual wild type Waldenstrom's. However, the majority of Waldenstrom's will respond to this type of therapy. And we recognize that some of the side effects are that ibrutinib, although it's a pill, needs to be taken as long as it controls your disease. It does have the potential side effects of causing atrial fibrillation, which is an arrhythmia of the heart, and can cause bruising and bleeding. Now, one of the things that we always look for in the world of heme malignancies is combining some of our therapies to improve response rates. The INNOVATE study was a groundbreaking study comparing giving rituximab alone versus rituximab plus the Bruton tyrosine kinase inhibitor ibrutinib. As we can see here, although the Rituxan in and of itself gives us response rates around 50%, once we start combining Rituxan with ibrutinib, we see response rates that are much closer to 90 to 100%, including even some of those patients with dual wild type. So this has become a standard of care for many patients with newly diagnosed Waldenstrom's because it's an extremely effective therapy. One of the things that we've now seen are what we call second generation Bruton tyrosine kinase inhibitors, drugs like zanubrutinib and acalabrutinib, designed to compound on top of just the high response rates of drugs like ibrutinib, but also improve the side effect profile. The phase 3 ASPEN study was a groundbreaking study for Waldenstrom's and was a head-to-head study comparing zanubrutinib for ibrutinib in patients with MYD88 mutated Waldenstrom's, remembering that still about 90 to 95% of all Waldenstrom's is going to have an MYD88 mutation. As we can see overall, we know that in both groups we saw extremely impressive response rates. However, overall, Those deep responses were seen more commonly with zanubrutinib, and it represents not necessarily that more people respond, it's that they have better and more durable responses. Additionally, what we saw in the Aspen trial is the risk of some of those side effects we noted with ibrutinib, like atrial fibrillation, were significantly reduced when we used zanubrutinib over ibrutinib. So for many patients, the first BTK inhibitor we may use is zanubrutinib because it tends to provide somewhat deeper and better responses and has a better side effect profile. Just like BTK inhibitors, there are other pathways within the abnormal cells that we have oral drugs to block. Most notably, there's a pathway that involves something called BCL2. Lymphocytes and certain plasma cells are dependent upon BCL2 to live, and Waldenström cells, being lymphocytes, are dependent upon this. So, oral inhibitors of BCL2, drugs like venetoclax, can be used to stop the cells from growing and kill them. And again, the benefit of a drug like this is that it's just a pill. And compared with the BTK inhibitors, venetoclax is not a therapy that's typically given until progression or intolerance, but can be stopped at any time. Here we see some great phase 2 data, which was presented by Jorge Castillo, one of the world leaders in Waldenström's. And we can see from the waterfall plot that essentially everybody responds to this type of therapy. We see really deep responses, and this is one of my go-to therapies for patients with Waldenström's. Now, I had mentioned previously that we can consider the use of therapies that are more tuned towards myeloma than lymphoma, seeing as Waldenström's lives in between these two worlds. And one of the mainstays of therapy for myeloma are the proteasome inhibitors. The best way to think about proteasome inhibitors are that every cell in the body makes garbage as part of its daily activity. There is a natural garbage disposal system within the cells to get rid of the garbage. Because these immune cells make extra proteins, extra globulins, extra antibodies, that's basically garbage. And the proteasome inhibitors, we like to say, throw a shirt into the garbage disposal system. So these cells can't get rid of it, they fill up with the garbage and they die. There are 3 FDA-approved proteasome inhibitors: bortezomib or Velcade, carfilzomib or Kyprolis, and ixazomib or Ninlaro. This is an IV, subcutaneous, and oral version of this type of drug, and these drugs can be given either by themselves or in combination with some of the immunotherapy like Rituxan. And again, these therapies can often be given for limited duration and have well-tolerated side effect profiles. So when it comes to the safety profile, this helps us kind of narrow in on what drugs we might want to use for an individual. Because we have so many efficacious drugs, we need to often think of the downsides and what types of side effects patients may or may not tolerate. So for example, Rituxan is a highly efficacious drug, but because it can cause that flare in the IgM, we typically hold off in patients who have a very high IgM up front. Additionally, this will kill normal lymphocytes, meaning your cells that make normal antibodies may decline, and you can become what we call hypogammaglobulinemic, meaning you don't make the normal antibodies to fight infection. And therefore, there's an increased risk of infection when we give Rituxan. Nucleoside analogs are classical chemotherapy drugs, and we have learned that although these drugs can be highly effective, because they function to kill and affect a lot of the normal cells, they do carry with them a risk of causing a secondary cancer like myelodysplastic syndrome or acute myeloid leukemia. Proteasome inhibitors are highly utilized as well, although certain drugs like Velcade can cause peripheral neuropathy, that's numbness and tingling in the fingers and feet, and they can lower blood counts like the platelets. Bendamustine is a classical chemotherapy that's somewhere in between what we'd call an alkylator and a purine analog. These drugs are highly effective, especially for patients with very bulky disease. And for patients who present with hyperviscosity, one of the go-to regimens would be to undergo plasma exchange to lower the IgM, provide bendamustine to lower the disease, and add rituximab once the disease has an IgM below 4,000. Again, because this is a classical chemotherapy, it can lower the blood counts quite a bit. And ibrutinib, we've talked about as a bruton tyrosine kinase inhibitor, is a pill. It can lower the blood counts a little bit, but the 2 biggest side effects we look out for are atrial fibrillation and bleeding diatheses or any bleeding or bruising. Now, we have a lot of therapies on the horizon to continue to fight this disease. And there are a number of key categories that we look at, and this list is not exhaustive. There are many additional therapies, but these are some of the most important and far advanced ones I'd like to talk about. Rituximab is an anti-CD20 antibody, and they've been used in diseases like Waldenstrom's for many decades. There are next-generation anti-CD20 antibodies, including ofatumumab, obinutuzumab, and others. CD38 is a marker that is used primarily in the myeloma world. However, Waldenstrom's can express CD38 as well. Therefore, we have anti-CD38 antibodies like daratumumab and isatuximab. Now, 30 to 40% of patients with Waldenstrom's may have a CXCR4 mutation. There are a number of drugs in clinical trial, including ulucuplimab and mavorixafor, that focus on patients with that specific genetic abnormality. CD52 is located on essentially all hematopoietic tissue, essentially everything except plasma cells. So drugs like alemtuzumab can be used. Again, it's a little of a scorched earth phenomenon because you kill a lot of your immune system. They're highly efficacious drugs, but infections are a big concern with that line of therapy. And again, we have some more novel Bruton tyrosine kinase inhibitors, including acalabrutinib and pirtobrutinib. Now, the other thing that we look for is combining therapy, because as we saw with the INNOVATE trial, when we combined ibrutinib with rituximab, we saw unprecedented response rates, somewhere between 90 and 100%. As such, we're looking towards a number of ongoing studies combining some of our already known effective therapies. Most notably has been an ongoing study combining ibrutinib and venetoclax, the Bruton tyrosine kinase inhibitor, along with the BCL2 inhibitor. The wonderful thing about this combination is that it's an all-oral regimen, which is highly advantageous to allow patients to continue to live their lives, undergo oral treatment, and not have to be in the clinic regularly for therapy. We also have an ongoing study that's mostly being done in coordination between Weill Cornell and the Mayo Clinic, involving daratumumab, the anti-CD38 antibody, along with ibrutinib in patients with Waldenstrom's. Very much looking forward to this upcoming data. And again, for patients whose tumors have both the MYD88 and the CXCR4 mutation, is an ongoing study looking at mavorixafor and ibrutinib, again, trying to take the more direct approach by specifically focusing on the two most common genetic abnormalities in Waldenstrom's. Very excited to see this data read out. In conclusion, Waldenström's macroglobulinemia is an uncommon subtype of non-Hodgkin's lymphoma, which is characterized by a bone marrow infiltration of a lymphoplasmacytic infiltrate and a monoclonal IgM in the blood. The diagnosis can be challenging, and we need a variety of tests, including standard laboratory blood tests to look at blood counts, to look at protein levels, antibody levels, and ultimately a bone marrow biopsy to evaluate for the bad cells themselves, and if they have any of the classic genetic mutations such as MYD88 and CXCR4. There are many therapeutic options for Waldenstrom's. Some patients may not even need any, especially those with smoldering Waldenstrom's, meaning Waldenstrom's without any active symptoms. For those with symptoms, because this is a lymphoplasmacytic lymphoma, we have options from the lymphoma world as well as the myeloma world, and we can mix and match based off of efficacy, based on side effect profile, based on the kinetic of disease presentation, and ultimately patient preference. There is a wealth of ongoing clinical studies looking to not only optimize current therapies, but ultimately cure the disease. And this involves looking at novel antibody-based therapies targeting CD20, CD38, and CD52, new novel non-covalent and covalent Bruton tyrosine kinase inhibitors, next-generation BCL2 inhibitors, and additional immune-based T-cell redirection therapies. And with that, I'll turn it over to our amazing host for the Q&A section.
Thank you so much, Dr. Richter, for all this information. And as you mentioned, it is now time for our question and answer session of our program. We've gathered questions from Waldenström patients who have reached out to our information specialists, as well as those who have participated in our online chats and community. So, Dr. Richter, the first question is, I don't need treatment right now, but it's really hard to hear that. I just wish there's something I can do. Is there support for me and my partner even though I'm just being actively monitored?
So, this is a really wonderful and very critical question. And I think one of the things that blood cancer patients face is this sort of Damocles hanging over them, even in scenarios where they don't need therapy. I think there are a variety of both social and interventional options out there. One is make sure you can take advantage of things like patient support groups and caregiver support groups through many of the patient advocacy groups like Blood Cancer United. Additionally, you can reach out online to them, and it may be worthwhile to talk to your care team about additional studies that may be looking into the risks or benefits of early intervention. Additionally, I would recommend the tenets of good, healthy living have positive impacts, not just in general life, but especially in the world of malignancy. Eating well, exercising, and getting good sleep, and stress and anxiety control. All of these are easier said than done, and everything in moderation, including moderation. So it's okay to have the piece of cake. But these general tenets of healthy living may actually improve some of the outcomes and is a way to take an active role even in a surveillance portion of your care.
The next question, are there any numbers, level, or markers or mutations I should pay attention to know if I need treatment or if I'm at a higher risk of needing treatment sooner?
Absolutely. So, one of the main numbers we look at is the total IgM number. But again, it's not just about the total IgM, it's also about what happens over time. This is a movie, not a snapshot. Meaning, I've had patients where the IgM has been 4,000 and it stays at 4,000. And if it's level and not moving, those patients will often not need therapy. But if your IgM is rising 1,000, 1,500, 2,000, that's something that may warrant therapy at some point in the near future. Additionally, the most crucial numbers to look out for are your blood count numbers on your CBC or your complete blood count, most notably the hemoglobin and the platelet count. Again, those numbers may be mildly low, but are they dropping? If your hemoglobin is going from 12 to 11 to 10, or your platelet count is going from 200 to 150 to 100, this may indicate that the process is growing inside the bone marrow and you may ultimately warrant therapy at some point.
Okay, thank you. Next question, after starting treatment, what about special vitamins or diets that I've heard about? How will I know if they're safe?
So it's really important to address specific dietary concerns with your care team because certain dietary foods or supplements may impact your care. As an example, if you receive bortezomib as part of your care, having green tea on the same day of your injection may negatively impact the efficacy of that drug. So, making sure that you're open to talking to the nutritionist, the nurses, the PAs, NPs, and MD of your team to talk about all of your concerns with them. In general, there are no specific diets that patients must have while they're on therapy with Waldenstrom's, but it's important to let your care team know about any additional supplements that you have, as there may be additional interactions.
Thank you. Next question, is there an environmental cause for Waldenstrom's or certain risk factors that cause Waldenstrom's and can it be inherited?
Really great question. So there's no clear environmental lead towards Waldenstrom's. However, there are certain cohorts of people that may have had certain environmental exposures to things like ionizing radiation from 3 Mile Island or Chernobyl that seem to have an increase in different types of malignant conditions. Hereditary Waldenstrom's is an extremely rare phenomenon. In general, if you have a first degree relative with a B cell process like Waldenstrom's, it essentially doubles your relative risk of having a disease like this. But remember that in absolute terms, that's very little. Meaning, if in the population it's 1 in 100,000 for that first degree relative, which would be a parent, brother, sister, or child, it then gets to be 2 in 100,000. So it's not one needle in a haystack, it's two needles in a haystack. So again, even if you do have a first degree relative with a disorder like Waldenstrom's, your family members are extremely unlikely to develop anything like that as well.
Okay, thank you. And if I have Waldenstrom's, am I at a higher risk of getting another cancer?
Really great question. There are subtle increased risk of non-melanomatous skin cancers, so it is worthwhile to maybe see a dermatologist once a year just for a full evaluation. Depending upon what types of therapy we use, there may be slight increases in risk of getting a secondary malignancy. So this is something to discuss with your team, that when you embark upon a course of therapy, does that course of therapy carry with it any increased risk of second cancers? But in general, most of those are blood cancers and will be monitored along with your regular Waldenstrom's laboratory studies.
Okay. And is Waldenstrom's different if you're diagnosed at a younger age, or is it treated differently if you're younger?
So another really great question, and a lot of this has to go with treatment goals and expected outcome. Again, when I've seen patients with Waldenstrom's in their 20s and 30s, and although things like the Bruton tyrosine kinase inhibitors are extremely effective, I don't like to put people on lifelong therapy ever, but especially when they're going to live another 50, 60, or 70 years. So to me, I have more of a predilection towards using fixed duration therapy and the ability to use more aggressive therapy in younger patients if need be. But again, all of the specific risks and benefits need to be explicitly discussed with your care team.
Okay, thank you. And the next question, I've heard other patients say that the disease has affected their eyes. Can you discuss this potential side effect?
Absolutely. So it turns out that when blood gets viscous, it can cause sludging in blood vessels. It turns out there's only one place on the body to look at blood vessels in real time, and that's with an ophthalmologic exam looking at the blood vessels in the retina. So all patients with Waldenstrom should have an ophthalmologic evaluation at least once a year to make sure that there are no vascular changes in the blood vessels in the back of the eye. This is absolutely critical. It tends to be more common with higher IgM levels. So if you have an IgM of 4,000 and above, it is definitely critical to evaluate for this, as I've had patients who had no other symptoms, but when I sent them to the ophthalmologist, they had eyes that looked like they were 40 years older with severe diabetes because of the changes in the blood vessels. It's much less common for people who have lower IgMs. However, it's absolutely critical to have your eyes evaluated at least once a year if you have a diagnosis of Waldenstrom's.
Thank you. And should I still get vaccinations if I have Waldenstrom's, so COVID, flu, shingles?
Absolutely. The specific types of vaccinations and the timing should be discussed with your care team. Because most therapies with Waldenstrom's will lower the immune system at some level, that does put most patients at a slightly higher risk for infections. So, protecting against these infections with vaccinations is key. However, timing is also key, as some of these therapies may hamper not the safety of giving the vaccines, but their efficacy. If we're lowering your body's ability to make antibodies and we give you a vaccine, you won't make antibodies against that vaccine. So always discuss your vaccination plan, especially around cold and flu season, with your care team.
And we've also heard that proteasome inhibitors, which you've mentioned, have a higher rate of causing shingles. Is that also something that patients have to take a precaution for?
Absolutely. So I think that for patients treated with proteasome inhibitors, I always put them on an antiviral prophylactic pill, such as a cyclovir or valacyclovir. And although some patients, when they're about to go on it, tell me, oh no, I've had the shingles vaccine, I explain that vaccines are very much like planting seeds in the garden to grow. They need to have good, proper soil to sprout vegetables and fruit and flowers. And because the bone marrow in someone with a blood cancer may not be normal, it's like putting seeds in the desert, and even the best seeds may not grow. So, although patients may receive vaccines, they may not have full protection from that vaccination, and I never want to take chances. So, anyone on proteasome inhibitors should be on an antiviral pill such as a cyclovir or valacyclovir.
Thank you. Next question. I'm 70 years old and pretty healthy other than the Waldenstrom's. Am I still a candidate for a stem cell transplant?
It's a really great question. And, first off, I'll say that stem cell transplant is not as frequently used in Waldenstrom's anymore because we've had so many amazing therapies that it's somewhat not as common and not needed, except mainly for patients who've had multiply relapsed Waldenström's, where it may make more sense to do what we call a beam autotransplant, meaning the transplant given with drugs called BCNU, etoposide, Aracy, and melphalan. However, if you were to need a transplant, I think I would say the classical statement that age is just a number, and it's really about your physiologic age, not your chronologic age. Again, I say this with a grain of salt. Someone who's over 100, even in their best physical condition, is probably not going to warrant a transplant. However, I would gladly take someone who's over the age of 70 to an auto transplant if needed, if they're healthy, quicker than I would someone in their 50s who has extensive other medical problems such as cardiovascular disease or chronic lung disease.
Thank you. And is transplant a potential cure for Waldenstrom's or even CAR T cell therapy in the future?
So, I think one of the things that we're really looking for ultimately, besides just optimizing our day to day therapy, are curative modalities. And in general, when we talk about the two broad categories of lymphomas, the high grade aggressive or low grade indolent, the high grade aggressive always warrant therapy and are classically curable with standard approaches. The indolent lymphomas, like Waldenstrom's, are not typically cured with standard approaches. Auto transplant and CAR T can provide extremely durable remissions, but are not clear, upfront, guaranteed cures at this time. Now, there are ongoing studies looking at a lot of our immune therapies like CAR T. And the question is, if it puts you in remission so long you never relapse, was it a functional cure? We still need ongoing clinical trials to answer this because, as opposed to some diseases where we know up front, high chance of just yet with diseases like Waldenstrom's.
Thank you. And I know that you mentioned combinations. Is it always better to get a combination of medications to control the disease?
It's a really great question. And the short answer is no. This really depends upon what symptoms you're having. How quickly do we need to turn it around? What are your other medical conditions? So, a lot of these things factor into it. For example, I have many patients who have minimally symptomatic disease and only have a rogue antibody lowering their platelet count. I just give them single agent Rituxan because if that's all you need, you avoid the extra potential risk of side effects when you use combination therapy. So it's all about dissecting out all the risks and benefits. And sometimes one drug is all you need, and sometimes several drugs are needed to control the disease.
Thank you. And our last question today, what are you most excited about with the newest therapies for Waldenstrom's?
So I think you already mentioned one of my favorites. Things like CAR T cell therapy are really changing how we approach Waldenstrom's and many other malignant blood cancers, in that many patients with Waldenstrom's are not going to require more aggressive therapies like CAR T. And the majority of patients either don't need therapy or are easily controlled with our current armamentarium. But there still exists a subset that are recalcitrant to many different treatments, and having the future potential of things like CAR T to not only recapture disease for those patients, but maybe even providing a cure is extremely exciting.
Well, thank you. Thank you so much, Dr. Richter, for volunteering your time today and your expertise with us. For more information or resources, you may speak to an information specialist at 1 800 955 4572 from 9 a.m. to 9 p.m. Eastern Time, or reach us by email at bloodcancerunited.org/contact us. You may also reach out to one of our clinical trial nurse navigators in our Clinical Trial Support Center. Our nurse navigators can identify Waldenstrom's clinical trial options for you or for your unique situation. If you've not already done so, please make an appointment with one of our nutrition educators. They are registered dietitians that can answer questions for patients and caregivers with any type of cancer. They are free consults, and you may contact them by visiting bloodcancerunitednutrition.org. Or you may call them toll free at 877 467 1936. Blood Cancer United offers financial assistance to help individuals with blood cancer. For more information, you can visit bloodcancerunited.org/finances. We also have started a medical debt case management program that provides one on one, in depth personalized support to empower patients to address their medical debt. They may be reached at bloodcancerunited.org/medical debt or by calling 833 507 8036, 8:30 a.m. to 5 p.m. Eastern Time, Monday through Friday. Your feedback is important to future patient education, so please complete the program evaluation by using our QR code or type in your browser www.bloodcancerutd.com/eval. Again, www.bloodcancerutd.com/EVAL to complete our evaluation. Thank you for joining us. Goodbye, and we wish you well.